So, good evening, doctor. We have basically for EDIC, you have these case based scenarios and case uh, vignette scenario. So, you will be required to know the stepwise approach as to how to arrive at number one, understand the presentation, that the question the patient in question has a condition. So the condition will not be told to you, it will be the chief complaints that will be told to you, and from those chief complaints you will have to arrive at a diagnosis which would then become complicated or get better as you pick up the options. Is that okay?
Yes, sir.
So that means for the most important critical aspects of a disease, you need to understand how does it present. That means how does it manifest, and what workup you can do to confirm your physical findings. Whatever you have checked the patient from history and physical findings, what extra investigation you will do, because every investigation will be accounted for. Why did you do this? Why did you not do this? So you will arrive at a diagnosis and then perform some tests to arrive at a confirmed diagnosis, and then plan treatment of the disease, then plan a monitoring plan. From that you will take lead to identify any complications that arise and manufacture a plan B where the complications can be addressed in the same patient. So this is what basic critical care is. We try to stay ahead of the complications of a disease. So first we identify the disease, then we stage the disease as to how much treatment does this patient require, and then we try to look for any impending complications and then identify them, diagnose them and treat them. And this is how we can save the patient. Is that okay?
Okay, sir.
So the first case that I'll be discussing is pulmonary embolism. Now, pulmonary embolism is a very, 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 very normal. Uh, where did my phone go? Can you see the screen?
Ah, yes,
Can
sir.
you see, can you see the screen?
I
Yeah,
can
it's
see
working.
its screen.
I don't know where my yeah, here it is. So pulmonary embolism is the most one of the most important case-based scenarios that you can get in EDIC. So,
Oh,
pulmonary embolism, you understand that it is the obstruction of either the main pulmonary trunk or the branches by a thrombus. Now, we have to identify, is it thrombus? Is it air? Is it fat? Or is it amniotic fluid? Because all of them can perform pulmonary embolism. So, what we will be discussing here is obviously thrombopulmonary embolism, but it can be seen in any of the four conditions. It can be air, it can be thrombus, it can be fat droplets, or it can be amniotic fluid. So, the presentation will be similar. Why? Because the flow to the pulmonary circulation will be affected. So, in case based scenarios, what usually you will get is a massive PE. Now, how do we define massive PE? There are three types of pulmonary embolism. In fact, now there is a fourth type also that we will just discuss. So, the first type is mild pulmonary embolism that usually presents with, patient coming with uh, breathlessness on exertion. So, it is a more of a OPD type of a patient. Then comes the moderate and then massive or submassive. Now, this This moderate means the patient has dyspnea out of proportion to the condition that the patient has. And massive and submassive is when the patient is literally come to the hospital either in a collapsing condition or already collapsed. That means the patient will present with a circulatory shock. So that is massive PE. So the patient needs to have a sustained hypotension. It is a very high risk situation. Systolic blood pressure less than 90 for more than 50 minutes. And you require vasopressors or there are signs of shock. What are the signs of shock?
So altered mental status, any
Great.
capillary refill time is prolonged, cold peripheries, and
Cold periphery. So circulatory failure will be there and urine output will be low,
yes,
decreased.
yes, sir.
So it is basically shock is defined as end organ involvement.
Yes, sir.
That is one line definition. So either the brain is involved or the kidneys are involved and their functioning is affected because of decreased blood flow to the organ. Now that is shock. So you identify that this is not due to any other cause of arrhythmia, hypovolemia, septicemia, or something like that. It is not there. Then there comes submassive PE, where you know this is intermediate risk, where the patient has normal blood pressure but is dyspneic on exertion. There is tachycardia, and mind you, tachycardia is the first feature of pulmonary embolism because whenever that happens, immediately the body goes into a sympathetic stimulation, plus it goes into an overdrive kind of a situation where it has to maintain the cardiac output with a decreased stroke volume status because stroke volume is coming from the pulmonary circulation to the left ventricle. Na? So if the pulmonary circulation is affected, left ventricle is not getting adequate amount of blood, so stroke volume is decreased, so heart rate will increase to match the cardiac output. So tachycardia by far and large is the first and most important first sign of pulmonary embolism. Then comes secondary things like peripheral circulation, peripheral blood pressure, ABG deterioration, urine output drop. The first sign will be pulmonary embolism, will be tachycardia. So submassive patient will also have tachycardia. There will be RV dysfunction. Why RV dysfunction will be there? Because RV tends to pump blood only to the lungs and it is a low pressure circulation. The moment the circulation gets a high pressure situation, the RV, which has not adapted to this high pressure circulation, will dilate. And it is on echocardiography, it is typically seen as a D-shaped septum. So I will show you when my iPad turns on. Then there is a low risk P where you know that there is no RV dysfunction or troponin rise, and only on a incidental CT pulmonary angiogram that you will get to know that patient has a pulmonary embolism. That is subtly present as dyspnea on minimal exertion. That you tell the patient to do a 6-minute walk test and during 6-minute walk test they desaturate. So but you've done the echocardiogram and you do not find anything. You do not find anything on an echo, you do not find anything on a peripheral doppler, but the d dimer is elevated and the patient desaturates on a 6-minute walk test. What does this mean? This means occult pulmonary embolism, that is it has been happening for a long time and now the patient has dyspnea. So you do a CT pulmonary angiogram and you diagnose the condition. The last but not the least is basically CTEPH. CTEPH. It is grade 4 pulmonary hypertension secondary to chronic thromboembolism. So CTEPH. Okay, that is CTEPH. So what will be the clinical features? Usually in the question stem, you will have a patient who usually has a history of traveling more than 4 to 6 hours, has a history of injury to the legs, has a history of cancer, has a history of being bedbound, has a history of being operated for any surgery like a laparotomy or a limb injury or even pregnancy or a fractured long limb, long bone fracture taken up for a surgery. This will be the setting of the question. And then there will be sudden onset dyspnea, there will be chest pain, there can be hemopsis, and if it is a massive pulmonary embolism, the patient will have a history of syncope. So in syncope, we define syncope as cardiogenic, neurogenic, vasogenic, But then in cardio and vaso, somewhere in between, you have pulmonary embolism as one of the important causes of syncope. Is that clear?
Yes, sir.
So you should look for these small words in the question stem. Then the cardinal sign of pulmonary hypertension, or basically pulmonary embolism, is tachycardia. So tachycardia will be there. If it is a submassive or a massive PE, hypotension will be there. And because the pulmonary circulation is affected, the right ventricle will be affected, then RA will be affected. And when RA gets affected, the JVP will rise. So there will be a rise in JVP. So much so that if you sometimes put a femoral venous cannula to a patient, it will have a jet-like, arterial jet-like situation. Why? Because the pulmonary circulation has higher pressure than the systemic pressure. Why? Because systemic pressure is low because of low cardiac output, and pulmonary pressures are more because of the stuck thrombus in the pulmonary artery. So the venous pressures will rise more and above the arterial pressure. So pulmonary vascular resistance will be more than the arterial vascular or systemic vascular resistance. Last time we had a patient of pulmonary embolism, and we checked the patient. He had a submassive PE. You will not believe, the pulmonary artery pressure was 90/50, and the systemic pressure was 70/30. So can you imagine, this patient was cold, clammy, very breathless, severe metabolic acidosis, and there was a big clot lying in the pulmonary veins. So when the pulmonary artery pressures are more than the systemic pressure, this is called pulmonary hypertension. When it happens suddenly, it is secondary to pulmonary embolism. So there will be right heart strain signs. They can either be seen on the ECG or on the echocardiography. On the ECG, it will be S1Q3T3. Everybody knows, with the right bundle branch block. Why right bundle branch block? Because there is a sudden dilatation of the right ventricle. And the his bundle that is conducting to the right ventricle will now need more time to conduct the impulse that is coming from the SA node, AV node, to reach the outermost edges of the right ventricle to conduct the right bundle branch block will happen. The right side conduction is now delayed. It requires more time. So there will be RBBB pattern. And you can see T wave inversions in V1 to V3, which are like an in part of uh, right ventricular strain pattern. This is the ECG part. Then you might get an echo in hints in the question as well. As the questions will progress, they will keep adding on investigations to you. So the echo will show RV dilatation. So when the RV becomes larger than the ventricle, it becomes a D-shaped morphology, which is known as McConnell's sign. I my When my iPad still not charged, otherwise I would have drawn the diagram and shown it to you. Maybe it works here. Yeah, it can. So basically, if this is the photo of the short axis, then you will have situation like this. So this is the right ventricle and this is the left ventricle. And when the right ventricle becomes D shaped, it's called McConnell's sign, and it's a D shaped uh, it's a D shaped septum. All right. So how will you diagnose in a patient who is in the shock or is clinically unstable? See, the guidelines now have 1B uh, certification for thrombolizing a patient who is dying, who is having a cardiac arrest. And if the history is suggestive of pulmonary embolism, you can thrombolize the patient even during CPR. So because in echo, it might show a D-shaped right ventricle and suggest you that the patient has a pulmonary embolism. But sometimes you just have to go by your clinical sense. So, in a patient of shock who cannot be transferred to CT pulmonary angiogram, just do a bedside echocardiography, assess the RV dysfunction, and plan for thrombolysis. If the patient can be taken for a CT pulmonary angiogram, then fine, you can take the patient and define that the patient has a pulmonary embolism and then plan a thrombolysis. I will tell you the core topics that will, mistakes are made That is how to start anticoagulation after you have thrombolized the patient. So once you have thrombolized, many people feel that the anticoagulation should be started on the next day, in 2 hours, in 8 hours. So there are guidelines for it. Look for any hypoxia, hypocapnia, metabolic acidosis, or respiratory alkalosis initially. So all kind of ABG pictures can be present in pulmonary embolism. But hypoxia will be certainly the most consistent finding. The patient initially can have hypocarbia, later they can have hypercarbia. The patient initially may have tachypnea associated respiratory alkalosis, and eventually, because of metabolic failure, this patient will eventually have metabolic acidosis. But hypoxia will be a certain feature in all the ABGs because the oxygen transfer is affected completely. Then in the ECG, look for the RV strain pattern S1, Q3, T3, and T wave inversions in V1 to V2 and right bundle branch block. D dimer requires a long time. 6 hours is the minimum return time for a D dimer. By that time, the patient would have died. So, if in the question you see that there is a massive pulmonary embolism, never ever mark a D dimer test. D dimer test is to be ordered only in a stable patient. And then comes CT pulmonary angiogram. Again, for an intensivist, for a critical care physician, it is very important that CT pulmonary angiogram will be done in a patient who can be shifted to CT pulmonary angiography. If the patient is, if you know that the patient might arrest on the way, or maybe arrest in the CT room, you are not going to send this patient, transfer this patient for a CT pulmonary angiogram, although it is a gold standard for diagnosis. But if the patient is not stable enough, echocardiography is okay to get the thrombolysis done. In lab tests, you need a TROP-T, BNP, fine coagulation profile, renal, liver dysfunction, lactate will be elevated. And as more and more the lactate is, more and more the shock severity is. So let's see the EDIC case scenario example. A 54-year-old man presenting to your ICU with syncope and severe dyspnea. Blood pressure is 82/50, heart rate is 124, respiratory rate is 34, saturation is 88% on 15 liters non-rebreathing mask. So as of now, it looks like probably a septicemia patient, right? Pneumonia will also present like this. Diabetic ketoacidosis will also present like this. So all the features, hypoxia, tachycardia, hypotension, tachypnea, oxygen requirement, 15 liters per minute. JVP is raised, so looks like heart failure. JVP is raised. Gradually, the case will progress. ECG shows S1, Q3, T3 pattern. So in the question stem, they will definitely give you something that distinguishes it from all the other differential diagnoses. But it will be only one factor probably. I have given all of them, but then it will be just one factor from which you can pick up that this patient has a pulmonary embolism. So ECG showing S1, Q3, T3 pattern may be replaced by ECG shows RBBB with T wave inversion in V1 to V3. At least you have to know it to see it, that it is there. Okay. Bedside echocardiography is done, which shows a dilated right ventricle and bowing of the IV septum towards the left ventricle. McConnell sign. Okay. So this has been clearly defined. So what is the stepwise management? As always, ABC. Initially, airway, breathing, circulation. Then oxygen. Already the patient is on high flow oxygen. Go for an NIV or intubate if needed. IV fluids. In this patient, the cardiac output is stroke volume dependent. So, because this patient will not have pulmonary edema, there will be pulmonary hypertension with basically decreased blood flow to the pulmonary artery. So you will need to increase the right ventricular pressures by giving small boluses of fluid like 250 to 500 ml. Vasopressors very cautiously. Why? Because norepinephrine will not only increase the systemic vascular resistance, it will also increase the pulmonary vascular resistance. Consider dobutamine if RV failure is there. Avoid overhydration. Now, diagnostic confirmation, bedside echocardiography. If the patient is unstable, if the patient is submassive, go for a CT pulmonary angiogram. What will be the scenario? Scenario will be a patient has been operated for a laparotomy for a perforated gut. It is day 4, patient is on ventilator, and the patient has suddenly begin to need more and more oxygen. You do a chest x-ray, but chest x-ray is clear. The heart rate is 124. The patient doesn't have any fever. The patient has blood pressure of 94/60. Mean pressure is still maintained. The urine output has begun to drop. Now you have enough time. That means you can shift this patient for CT, pulmonary angiogram. But you will have to keep the highest suspicion of pulmonary embolism because chest x-ray is normal. If the chest x-ray had pleural effusion, you would have a differential. If the patient had a consolidation, you would have a differential. Now that the chest x-ray is normal, it is not the pulmonary, it is the vascular. It is the pulmonary vasculature that is involved. It will not show on the x-ray. So you will need to get a CT pulmonary angiogram done. So for an intensivist, if the patient just has a DVT and a small pulmonary embolism, you can always, your patient is already on DVT prophylaxis, either on low molecular weight heparin or DVT stockings. Usually they have to be on the DVT prophylaxis. So now we will be required to tell that if the patient needs a thrombolysis. So patient will be needing thrombolysis immediately in case of massive PE. First line is altiplase, TPA, 100 milligram over 2 hours. So basically you give 10 milligrams as a bolus and then 90 milligram over 2 hours. Okay. And if the patient has cardiac arrest, what will you do?
Accelerated regimen can
So
give.
we will give 50 milligrams bolus.
Yes, yes.
Okay. What are the contraindications? If the patient is actively bleeding somewhere in the abdomen or in the brain, that is the absolute. Recent surgery is a relative. Prior ICH, relative contraindication. You should weigh the risks. Now, coming to anticoagulation. The anticoagulation has to be started simultaneously unless contraindicated. So that means once you have given the TPA, it should immediate, either it should be given along with it, or when the TPA stops, you should start heparin. Heparin or Clexane, low molecular weight heparin, either way. Okay? Stop unfractionated heparin during altiplase and resume when the altiplase is done. If the patient is already on heparin. Is that okay?
Yes, sir.
Now, monitoring, you all know, monitoring for bleeding, recurrent pulmonary embolism, or worsening right heart failure. Now, if this patient continues to have right heart failure despite proper anticoagulation and proper thrombolysis, now the pulmonary embolism has resolved. Pulmonary embolism has resolved, the saturation has improved, PA pressures have improved, but RV dysfunction persists. And that is why hypotension persists. What will you do? You will bring up the CVP to 16 to 18. You will keep the filling pressures high because that is what is required. If still it is not working, then you will add dobutamine. Number one is IV fluids in RV dysfunction. Number two is dobutamine. What is number three? If it is a resistant right heart failure, what is the next thing that you will do?
Mechanical support.
Say again.
VA ECMO?
Yes. The next step will be VA ECMO. Will you consider IABP?
No, sir. It only supports the left heart.
Very good. So IABP is the only mechanical device meant for left ventricle. So ECMO has an edge over IABP that it supports right heart also. Okay.
Yes, sir.
Special consideration. Saddle PE. Saddle PE is V-shaped PE. That is, it is in the root of the pulmonary artery and the clot is going into the both right and left. It may or may not be hemodynamically significant, but it usually is massive PE. If nothing works, then thrombectomy or catheter-directed thrombolysis. Now, catheter-directed thrombolysis has similar incidence of bleeding as the systemic thrombolysis. So many times this question is asked, what is the incidence of bleeding, relative risk of bleeding in catheter-directed thrombolysis or thrombolysis proper. So both of them have the same. If nothing works, then thrombectomy needs to be done. So if the RV failure has occurred, then I have told you that you need to optimize the preload, avoid hypoxia, and of course, if nothing works, then ECMO is the VA ECMO is the option. So after you have done that, the patient stabilizes. You can either switch the patient to low molecular weight heparin or to newer oral anticoagulants like rivaroxaban, apixaban, or dabigatran if there are no contraindications. Is it clear till now?
Yes, sir. So one doubt I had, sir.
Yeah, yeah, go on.
So that scenario that you just told me now, that patient had surgery 4 days back, no, sir?
Yeah.
So then should we say thrombectomy instead of thrombolysis?
So in this case, the it depends totally on the basically the surgical risk. If everything is properly done, properly closed, we have thrombolized so many patients. Even we have thrombolized hysterectomies.
Okay,
Nothing happens. Nothing
okay,
happens
okay, sir.
because ultimately, if the patient survives, TPA ka, how much is the half life of TPA?
1 hour, sir.
It is only few minutes.
Okay, sir.
I don't know why people are calling again and again. I've switched off my phone, but then they're still calling because of the Wi-Fi. Now they are just connecting, and it's bothering me. So basically, TPA, because it has a short half life, it doesn't make any difference.
Okay, sir.
Okay,
Okay, thank you, sir.
unless it is a neurosurgery.
Okay, sir.
Yeah. So afterwards, you diagnose provoked P or unprovoked. That is not a domain of critical care. So it has a high mortality. What are the problems that we usually face as students? Is failing to identify the shock as due to pulmonary embolism. As much straight case I have told, it may not be as straight a case. You will have to identify that this can be a pulmonary embolism, and then hesitating with thrombolysis, like you just said.
Mm. So,
So it is a life-threatening condition. If you, the patient will not die of bleeding because TPA doesn't, lead to a life-threatening bleeding. In case of brain, yes, because otherwise there is not space enough in the skull. Otherwise, though, you give, and then if the bleeding happens, give blood and eventually save the patient. But at that particular moment of time, massive pulmonary embolism, you have to just thrombolize the patient. Then overhydration, worsening RV strain. So your hydration should be enough that 15 to 18 centimeter of CVP should be there. Okay, not using vasopressor early enough. So you should be open to use vasopressors. And delayed anticoagulation post thrombolysis. It will give time again for the thrombus to form. So you should not delay it. These are the pitfalls which are usually seen. So I'll give you some MCQs. Number one, a 60-year-old patient in ICU with suspected pulmonary embolism is hypotensive, tachycardiac, and has a raised GVP. Echo shows RV dilatation and hypokinesis. So see, there very, very easy options are given. But if I just change it to a 60-year-old patient in ICU is hypotensive, tachycardiac with JVP raised. So no suspected PE word I add. Then it is an open game, right? So then echo shows RV dilatation and hypokinesia. So this either means the patient has a RV infarction or the patient has a pulmonary embolism. So what is the next best step? Number one, CT pulmonary angiogram. Number two, start LMWX. Number three, administer thrombolysis. Number four, start IV fluids. Or number five, order D-dimer. So will D-dimer be required here?
no, sir. Patient is unstable.
Patient is unstable. And if 2 liter bolus is not mentioned anywhere. So if we go from below, administering thrombolysis is one option. Though the patient is hypotensive and tachycardiac and raised JVP, theoretically you can get a pulmonary angiography done. But because the scenario is such that I am expected you to understand that this patient will crash any moment, so this patient should be given a
Thrombolysis massive.
thrombus. So this is a classical massive P. Thrombolysis should not be delayed. Okay. What are the contraindications to systemic thrombolysis in massive pulmonary embolism? active bleeding, recent major surgery, history of hemorrhagic stroke, intracranial neoplasm, recent ischemic stroke, or uncontrolled hypertension. So these are the specific contraindication that you should know. Active bleeding, recent surgery, major surgery, history of hemorrhagic stroke, because this patient definitely will die if you give TPA. Intracranial neoplasm will bleed again. Recent ischemic stroke will become hemorrhagic stroke. And uncontrolled hypertension will again bleed in the brain. So anything that leads to bleeding in the brain is contraindication. So what are the key takeaways? Number one, massive PE is equal to shock plus RV failure is equal to emergency thrombolysis. Echo is the key to diagnosis when CTPA is not possible. Do not delay thrombolysis in unstable patient. Manage RV failure supportively, oxygen, intubation, vasopressors, inotropes, IV fluids. Use anticoagulation when thrombolysis is complete. Never ever forget that the patient needs a anticoagulation. Any question?
Awesome.
So I did not venture into any criteria to diagnose PE because that would have led us astray. We, as critical care physicians, we need to understand how to act, when to act, what to do. Okay. Okay. Next is status epilepticus. Very important again. How do you define status epilepticus? More than 5 minutes of continuous seizure activity, or if there is no full recovery and two or more seizures happen, that the patient never recovered completely. Seizure happened, patient is still unconscious in post-ictal state, has not become conscious, and again goes into seizure. So, even if it is an interrupted seizure, then two or more than two, or a continuous seizure activity of 5 minutes. What is refractory status epilepticus? It is basically when you've given two anti-epileptic drugs, adequate dosing, adequate loading, including one benzodiazepine minimum, and the patient still continues to have a seizure. Now, there is another one which is super refractory, that you've given everything, including anesthesia. You've given propofol, you've given thiopentone, and the seizures are still persisting beyond 24 hours. These definitions are very important. Last time in my EDIC lecture, I was given the topic of cardiac failure, heart failure basically. So there is a definition of refractory cardiac failure, which is a different thing. Same way, when you deal with status epilepticus, it is status epilepticus, it is refractory status epilepticus, then it is super refractory status epilepticus. You should need to know the definition. Why? This is the staging of the disease. Correct? So the treatment will change with the stage. All right? So you can classify this. If the convulsions are there, then it is a convulsive status epilepticus, or more common in the ICU, a patient who was apparently well suddenly becomes non-responsive. You do an MRI, it's absolutely fine. You do a metabolic screen, it is deranged. Ammonia is elevated, calcium is high or calcium is low, sodium is high or sodium is low. Uh, Lactates are high, basically liver failure, kidney failure, electrolyte imbalance, septicemia, all of them can cause, or the patient has been exposed to certain drugs like cefepime, like meropenem, which can cause status, non-convulsive status epilepticus. So confusion, coma, subtle movements, EEG will be required. Why? Because otherwise, from outside, it is only AMS. AMS is altered
Altered
mental
mental
status.
status.
So it will be altered mental status with seizure activity on ECG. Focal status epilepticus is when patient continues to keep blinking the eye but remains conscious. Okay.
Yes, sir.
So let's see a case scenario. A 36-year-old woman with no prior history of epilepsy is brought to the emergency department after a 10-minute seizure of generalized tonic-clonic type. She remains unresponsive with ongoing seizures. Vitals: heart rate 140, BP 150, 190, saturation 92, GCS is 5. What is the diagnosis?
It is epilepticus.
It is status epilepticus. Why? From the question, which is the defining criteria?
10 minutes or more than 5 minutes it is.
Great. So, first 5 minutes, you will have to act very fast. You will have to break it. So, once the patient presents you, so the defining time of 5 minutes should be the treating time of 5 minutes. Because now the patient has come with the diagnosis, no? 10 minutes. So next 5 minutes, if it continues to remain the same, that means we could not change anything.
Okay.
So we have to act within that 5 minutes definition period. Number one, ABC, securing the airway, high flow oxygen, IV access, check blood sugar levels is the first test that you need to do. Because hypoglycemia is the biggest risk for status epilepticus. So whenever a patient comes to you in the emergency room with fits, the first test you should do is blood sugar levels. So check RBS. If you cannot check RBS, let us say in the question it is given that the sister who checks the blood sugar level is already checking sugar of some other patient on the fourth floor. What will you do now?
Give off the dextrose, sir.
Wonderful. So you give IV 50 ml 50% dextrose. Okay. Then give thiamine if the patient is known to have a history of alcohol or has Korsakoff psychosis or Wernicke-Korsakoff syndrome. Then, so first 5 minutes you have given hypoglycemics, or you have given glucose infusion and thiamine. Now, in next 5 to 20 minutes, what will you do? You've given the homework, and now you will set the stage for treatment. You will give benzodiazepines drug of choice. Number one, lorazepam. What is the dose? Zero point 0.1 milligram per kg. Maximum dose 4 mg. Make sure that the BP can fall. So, adequately hydrate the patient prior to lorazepam. Alternatives are midazolam or diazepam. This is the first line therapy. Lorazepam is the first line therapy. Second line is something else. Either it is levetiracetam,
Phenytoin.
or it is phenytoin, or it is valproate, or it is then lacosamide or phenobarbital. So these will be added as and when the
Required.
drug
If it's
doesn't work.
persistent.
Yes. For EDIC, choose levetiracetam, Levipil as we call the famous name, for its speed, ease of use, low interactions, and avoid phenytoin if the patient also has arrhythmia or liver disease.
Mhm.
Okay. So after lorazepam has been given, what will be the next drug to give?
Uh,
IV Levipil.
Levit.
ठीक है?
Yes, sir.
Then, if the 40 minutes have passed and the patient continues to have status epilepticus, then we'd call it a refractory status. Why? Because now one lorazepam, one other drug has been given. So, two drugs have been given. So, definition will be refractory status epilepticus. So, what will you do is without wasting, because otherwise brain will burn out. So, start the patient on anesthetic infusion, midazolam infusion, load them with zero point 0.2 milligram per kg IV, then go up to 2 milligram per kg per hour. For a 60 kg, you can go up to 120 milligram per hour to break if the blood pressure sustains. Or you can give propofol, thiopentone, and ketamine. And preferable is to get a continuous EEG done. And what is the aim? Aim is to get a burst suppression. And if you are going to give anesthetic agents, then you intubate the patient and put the patient on ventilator. Okay.
Okay, sir.
What will be the investigations? Blood sugar, electrolytes, sodium, calcium, magnesium, CBC, LFT, ABG, toxicology is very important. Then anti-epileptic drugs. So once I saw a patient of phenytoin toxicity. The
Mhm.
patient continued to have seizures. The patient was on phenytoin, but unfortunately the phenytoin levels were very high. So we gave the patient midazolam infusion very high and achieved a burst suppression. After stopping midazolam, fifth day patient woke up conscious without any residual seizures. So get a pregnancy test done for young females. Very important. This is out of experience I have added. Many times the patients are pregnant and they don't know it. So they have a very fast onset preeclampsia. early onset, or they have high blood pressure and they have a syndrome known as press. Okay, so it will present as status epilepticus. You have to correlate. And if you suspect any malignancy, oh sorry, infection in the brain, then you do a lumbar puncture. Okay. Imaging. CT head is urgent. If it is a new onset trauma or persistent unresponsiveness, minimum is CT, maximum is MRI. So CT should always be done. And then an EEG if possible. EEG is done to confirm the ongoing seizure, to detect any non-convulsive status, essential for refractory and super refractory. You cannot diagnose them without an EEG. You cannot treat them without a continuous EEG. Etiology is by the mnemonic of vitamins: V for vascular, stroke or hemorrhage; I for infection; T for trauma; A for autoimmune, limbic encephalitis very common; M for metabolic, hyponatremia, hypoglycemia, uremia, hyperammonemia, everything. I for idiopathic or epilepsy related. N is for neoplasm, and S is substance, delirium tremens, alcohol overdose, opioid overdose. Okay. So, what are the principles of management? Airway protection is the key because this patient is unconscious. GCS of less than 8, intubate. So, check if the GCS is less than 8, always intubate. Temperature control. Seizures will burn out the brain. So, keep the brain cold. If you have a helmet, cooling helmet, use the cooling helmet. Keep the brain cool. Monitor their lactates and rhabdomyolysis, potassium, hemoglobin, and uric acid and lactate. DVT and GI prophylaxis is very important. These patients can have a ulcer in the brain or ulcer in the stomach. So nutrition and sedation, weaning planning, ये तो fast hugs हो जाएगा सारा. Family communication, neuroprotection. Prognosis, convulsive status, 20 to 30% mortality is there. Non-convulsive is lower, but the problem is that we don't get to recognize the non-convulsive. Prognosis depends on etiology, how long the status remained, how fast did you treat, and age and comorbidities of the patient. What are the pitfalls that usually happen in the exam? Number one, we instead of benzodiazepine, we go for levetiracetam, phenytoin, lamotrigine, lacosamide, and other drugs. First drug will always remain benzos. Always. Even if it is phenytoin toxicity, benzos. All right. So delaying benzodiazepine, never delay. Not escalating quickly to second line drugs. See, you only have 20 minutes. First 5 minutes, give glucose and all. Then give benzodiazepine. Still the seizure not controlled, give another dose of benzodiazepine. Still not controlled, 20 minutes passed, add a second drug. After 40 minutes, add a third drug. That should usually be an anesthetic agent. Intubate the patient, put on ventilator, do the ICU protocols, use a cooling helmet, everything. Try ketamine if you have not tried it now. Try ketamine, try keto diet, try everything on the planet to cool the brain down and silence the brain. If the BP is going down, give fluids, give inotropes, but do not say that the blood pressure is low. How can we give anti epileptics? Because the patient will die otherwise. The brain death will happen. So, not escalating quickly. Escalation is the protocol.
Uh,
Overuse of phenytoin
Sir,
without.
sorry to interrupt. The other student have also joined us. Okay.
Very good, very good. So, overuse of phenytoin without considering cardiac risks. So, missing non-convulsive status in altered mental status. It is very important that you get to see the if the patient has altered mental status, then you should always suspect that the patient may have a non-convulsive tumor, status epilepticus. Now let's do a MCQ. A 55-year-old patient with septicemia develops a tonic-clonic seizure after more than 10 minutes. You give lorazepam, then you give levetiracetam. Seizure still persists. What is the diagnosis?
Super refractory status epilepticus.
Why do you say super refractory? It's not 24
Sorry,
hours.
refractory status epilepticus. He should give propofol
This
and
is
intubate.
good. So repeat levetiracetam, adding phenytoin, starting propofol, give mannitol, observe. So here we will have to give the anesthesia agent. So this is now a refractory status epilepticus. The main crux is intubate this patient and initiate anesthetic infusion. As simple as that. If propofol is not available, use thiopenton. Thiopenton not available, use pentobarbital. Not available, go for phenobarbital. Not available, go for ketamine. Even some people have used etomidate. But these are basically all anesthetic agents. So you use them. Why? Because now the diagnosis has changed. It is not status epilepticus, it is refractory status epilepticus. Okay, short questions. What are the indications for intubation in status epilepticus? Number one, prolonged seizure for more than 10 minutes. Number two, hypoxia or unable to ventilate the patient. Third is if you need anesthetic agents. Is that clear?
Yes, sir.
So, what are the takeaways? Status epilepticus is a medical emergency. Treat within 5 minutes. Used a tiered approach, that is, from status to refractory status, then to super refractory, and then stage the disease and then treat them accordingly. Refractory status will require intubation and ICU level care. Continuous EEG is important and look for reversible causes in all cases. So, what I've done is I've kept two more questions for status epilepticus because this is an important topic. Next question is a 55-year-old man presents with ongoing generalized seizure. He received 2 doses of IV lorazepam. Seizures continue. Which of the following is the next step?
Levetiracetam, sir.
So this is a status
Status
epilepticus. So what
epilepticus.
we'll give? We will give IV levetiracetam. Then we can take it to the next level. Supposedly now, even after adding levetiracetam, the patient still has seizures. So then you will start propofol. If it is 24 hours and the patient has not responded, now it is super refractory. Now what will you do?
Then you'll
You will just continue with the sedation and keep increasing the level of anesthetic agent until what is achieved?
first suppression.
Burst suppression. So, which feature best defines a refractory status epilepticus?
So C, sir. Not status epilepticus not controlled by benzos and one anti-seizure.
So, not controlled by benzos. So, what epileptic drug withdrawal or non-compliance? Second is electrolyte imbalance. Third is neurological infection or stroke. Is that okay?
Yes, sir.
Great. So, the next topic will be varices and GI bleed. Sana, can you
Yes, sir.
tell the third student to join also?
Yes, sir. Both have joined. All
Great.
three students
So
are
we
yeah.
have full house.
So it's my request to Dr. Mohammed sir and Dr. Janaki ma'am that please unmute your mic and also switch on the cameras. You can answer it accordingly, the questions. Thank you.
Okay, doctors, what we have covered is two topics. One was pulmonary embolism, and second is status epilepticus. So the third topic for today is varices and GI bleed. Very important. So I was given the most important topics which pertain to several organ systems in one class. So we've done like two. This is the varices and GI bleed. Very important. So how do you classify GI bleed? GI bleed is basically bleeding through any of the GI orifice, like either mouth or per rectum. So upper GI bleed is when the origin of the bleed is above the ligament of Treats, which is there in the, at the junction of first and second part of the duodenum. And the causes are usually esophageal or gastric or, gastroduodenal. So Mallory Weiss tear, all of them, they can be upper GI bleed. Lower GI bleed is anything below the ligament of treat. So diverticulitis or diverticulosis, angiodysplasia, IBD, which is inflammatory bowel disease, very common, ulcerative colitis, and neoplasms. So for a critical care specialist, diverticulitis is important as a lower GI bleed. None other is important. Neoplasms, IBD, not for us. Upper GI bleed carries a lot of importance. For emergency physicians, Mallory-wise tear carries importance. For us, probably patients in ICU usually don't retch so much that they will eventually have a GI bleed, because the moment they start vomiting, we give them some anti-nausea agent like ondansetron and all. So they usually don't get Mallory-wise tear in the hospital, but they may have a variceal bleed with which they were admitted or they develop it in the hospital itself. So, upper GI bleed, specifically variceal bleed, is one of the most important EDIC scenarios. Typically, with portal hypertension due to cirrhosis, and it has high mortality, requires urgent intervention. Usually, a case scenario will be like a 54-year-old male with known cirrhosis, alcoholic, presents with large volume hematemesis, blood pressure is 82 by 48, heart rate is 112, GCS is 14, abdomen is distended, caput medusae visible, sclera is yellow, is jaundiced, HB is only 7.6, INR is 1.9, platelets are 54,000. You are the registrar on call. This is a typical case scenario that you see in a patient of cirrhosis. So, this is decompensated cirrhosis. So, what will you do? Immediately, what will you do? So, these are the questions that usually come in the case based scenarios. What is the next step that you'll do? So, the next step is resuscitate this patient. Don't rush for doing bleeding control. Why? Because 90% of varices bleed, they are all venous bleeds. So they will stop in 24 hours. Only 10% will remain. That will require any active intervention. So what you require is immediate stabilization. How will you do it? Number one, assess your ABCs first. If the patient is drowsy, GCS is less than 8, or the patient is vomiting so much that he is aspirating, then intubate. Breathing, high flow oxygen should be given to these patients. Circulation, this is one of the conditions where patients can collapse very fast. So put two IV lines. Don't rush for central line. Veins will be collapsed. You may not be able to look for a central vein even with ultrasound guidance. Sometimes you cannot. You can locate the vein, but the guide wire will just not go forward. Why? Because the vein is collapsed. So immediately put two high bore IV cannulas, rush the fluid, preferably crystalloid, and to target a mean arterial pressure of more than 65. Then comes the transfusion guidelines. Anything less than 7 has to be transfused with a target of 9 grams. Platelets, give if it is less than 50,000, but otherwise,
Sir, viscoelastic testing should we base it on that later or
immediately you don't have to do that. So basically, when the platelets are less than 50,000, if you have a thromboelastography or a viscoelastic testing, fine, you can use. It is recommended also. But if your patient is actively bleeding, I think giving platelets will carry more weightage, correcting INR along with, than doing a testing.